Good afternoon, everyone. I am Joella Estrada. I am an ICU, Intensive Critical Unit nurse in a provincial hospital in Pangasinan. So, I was introduced a while ago. He is the more funny one, he's the academician, but I am a more serious one, maybe because I deal with critical patients. So, please bear with me. Don't sleep. Please listen. Okay. My study is on the ethical issues of family presence in the ICU and during CPR. So, let me ask all of you first. Have you experienced being in the ICU, or you may as a patient or as a relative of a family? Who among you have experienced being in the ICU? Okay, just a few of you. So now, can you imagine how an ICU patient look like? So who among you can describe or can imagine how a patient in the ICU look like? Clinically dead, yes, somehow. Okay. For us as nurses, we describe ICU patients as Christmas tree. Why Christmas tree? Because a lot of tubings and catheters are connected to the patient of different colors, and it's actually like this one, of different colors. A lot of machines are connected to the patient. Okay, so well, it's difficult for the patient, but most of the time, like what Ma'am Joella said, they are clinically dead, so the family member are the ones who are most affected. So, before I start my presentation, let me first read to you a case. This is an account from an occupational health nurse from Illinois. My father, who was 52, was admitted to the hospital for back pain, when in fact, he had a dissecting aneurysm. My mom and I were in his room and he was in radiology when I heard a code called to that department. Nothing was going to stop me from seeing what was going on down there. I had a sense that it was my father, and I needed to be there, so we went to radiology. Much to the staff's dismay, I insisted on being present during the code. I made sure that my mom had a chance to say what she needed in my dad's ear. In the end, I was the one who said enough, and I was the one who told my mom. I realized that being a nurse changes my perspective, but I am also a daughter and had to be there. If I hadn't seen the care given to my dad, the attempts made, it would have been very difficult for me to process what happened. Okay. This is just one example of the experiences that family members, everyone experiences, doctors, nurses, they experience being a family member of a patient in the ICU. So I think it is important to study the factors and the issues on the family presence, not only during visitation time, but also during CPR or resuscitation. Okay, so before I present to you my results, of course, there are issues to be discussed. Family presence in the ICU was based from the framework of patient and family-centered care. Before, it was patient-centered care, which primarily focused on the patient alone, and then another term was called family-centered care. However, family-centered care was used before to pediatric patients. Now it has evolved to patient and family-centered care, involving all the persons around the patient. Okay, so some issues identified. First, hierarchical relationships between doctors and nurses. In the Philippines, of course, the trend is already that nurses and doctors are co-equals. However, in the Philippines, there is still the presence of the traditional trend that nurses are inferior to doctors. So this issue is presented because most of the time in the hospital setting, nurses cannot decide for the patient because it is always the opinion of the doctors who are being followed in the hospital. It's like the doctors are the bosses and the nurses are the helpers. So why is it that way? We have two reasons. First, education, and second, professional responsibilities. In terms of education, the Philippine Bachelor of Science in Nursing is a 4-year degree course as compared to Doctor of Medicine, which requires a pre-med bachelor's degree, which takes usually 4 years, 3 years of academic and clinical duty, 1 year of clerkship, and 1 year of postgraduate internship. Both have a specialization progression, but nurses only take 6 months to 1 year for certification, while doctors need 3 to 6 years of residency period. Okay. Another reason for the hierarchy is the professional responsibilities of doctors and nurses. They are both leaning towards the same goal, which is to provide optimal care. Yet, there are still differences identified, and these differences can potentially, of course, widen the gap. Nurses are mainly obligated to follow the formal power of physicians and healthcare organizations in the implementation of care to patients. Nurses have to function, but still nurses have to function as patients' advocates. Okay, so there it is. I see nurses as the patient's advocates. Okay. Another issue to discuss is the use of advanced directives and shared decision making. So in the Philippines, advanced directive is an umbrella term for healthcare proxy and living wills. As defined by the Philippine Council for Health Research and Development, advanced directives are written, legally recognized documents that state your choices about healthcare treatment or name someone to make such choices for you if you are not able to do so. Maybe if you are unconscious or somewhat brain dead. However, the use of advanced directives as a written legal document is uncommon, especially in the provinces of third world countries. Choices of healthcare treatments are only asked to patients or families for consent for procedures, and to families for do not resuscitate requests, not for requests like the presence of family in the ICU because they feel that it is not that important. Okay, they do not ask the patient if the patient wants his or her family to be present with him or her in the ICU. Okay, another issue is the absence of written hospital policies on family presence during resuscitation. Family presence is promoted or supported by many medical and nursing organizations. They think that family presence in the ICU will produce better outcomes for the patient's health, and of course for the psychological or emotional aspect of the family. However, in the Philippines, there is no established policy on the presence of family in the ICU during resuscitation. Okay, in the province, as of our case, in the provincial hospital, families are allowed in the ICU 24 hours a day. However, they are led outside the ICU whenever the patient is on call or the patient arrests or when they do special procedures, invasive procedures. Surveys, research, and review articles that are published are primarily from the US, and very few articles have been found regarding the presence of a hospital policy on family presence in the Philippines. All hospitals have visitation hours for a minimum of 4 to 8 hours a day. But as regards to the situation during resuscitation, no hospital has established a clear policy. It is, however, being practiced, but the problem is there is no consistency. Primarily, it depends on the opinion or view of the doctor as the leader of the code. So if the doctor opted that the family be out of the ICU, he can do that. He can always do that because there is an absence of the policy. So, the purpose of the study is to identify ethical issues concerning the practice of family presence in the ICU, the issues that hinder and promote it, in particular to explore the roles of doctors, nurses, hospitals, and family members and patients in family presence. It is done to identify the factors in the practice and attitude of doctors and nurses on family presence in the ICU. This is to recommend the establishment of a hospital policy. So, the setting of the study, my base hospital, is a provincial hospital. It is 300 it has a 300 accredited bed capacity, but with 600 actual beds and 117 to 133% occupancy rate. What does that mean? One bed, there can be 2 patients in one bed. Okay, that is how many are patients that we cater. Okay, so sometimes even in the OB/GYN, we have 2 mothers and 2 babies in one bed. Okay. However, the hospital only has 1 intensive care unit, and this intensive care unit caters medical, surgical, and neurological cases. But this is only a 10-bed capacity unit. So a lot of patients outside the unit will reserve a bed in the ICU. There are times that the reservations reach up to 20 patients. Of course, the patients outside the ICU will wait until a patient in the ICU dies or get discharged. So let's proceed with the results. The study conducted was consisted of a survey and an interview. The survey part, the results on the survey part on the nurses' skills on ACLS. You can see that. Can you see the table? You can see that not all of the nurses are ACLS certified. ACLS is Advanced Cardiac Life Support. However, with question number 2, you can see that they all participated in a code. They are not certified. They are not all certified, but they all participated in a code. Okay, the doctors were not included in the first part of the survey because all the doctors are ACLS certified. Part 2, on the experience on family presence during resuscitation. There were 3 questions. Most of the nurses have experienced events that required CPR for more than 20 times in their entire nursing career. However, when asked about the number of times they have experienced a family member present in the room during CPR, most of them answered between 1 to 20 times. And they do not usually initiate family presence during resuscitation, basing from the 0 to 1 number of times of experience. All the doctors have a lot of experience in CPR. They have 6 to 10 times experience having a family member present in CPR and no experience in initiating family presence. Meaning, because yes, all the doctors out of 5 intensivists are doctors in the ICU, they do not want families to be present during CPR. Perceptions on family presence. Family presence is defined as the visitation of a family member in the ICU. The local doctors prefer that family members do not stay in the ICU, while international doctors think that visitation or stay of family members is needed because the nurses cannot stay all the time with the patient. One of the international doctors consider having the family members at night when they can just hold hands while the patient is sleeping. 8 questions were asked to get the perceptions of the doctors and nurses on FPDR. The majority of both the nurses and doctors would want to be present in the room if their loved one is being resuscitated. So that is the irony. As a healthcare team member, they do not want the family of a patient to be present during CPR, but as a relative or member of a family, they all want to be present when their loved one is being resuscitated. Okay, when asked if they think that patients do not want family members to be present during resuscitation attempts, more than half of the nurses answered yes, and almost all doctors agreed. All of them believe that family members will become disruptive if they witness resuscitation efforts. Most of them think that these family members are more likely to sue. Further, most think that the family members in the unit where they are working prefer to be present during resuscitation efforts. Lastly, majority of the nurses and all of the doctors think that the resuscitation team will not function well if family members are present in the room. Only a few of the doctors and nurses see the presence of family members during resuscitation as beneficial to the patient. Okay. These are the results of the interviews. So, the question on the general view of the healthcare provider, which includes the doctor and the nurses, were classified according to themes. Themes identified who are in favor of FPDR are, number 1, to gain better efforts of the resuscitation team. So, Nurse 4 said that the significant relative who is capable of making decision for the patient has the right to know what measures the clinical team would do during resuscitation of the patient, as long as he's not interrupting any procedure. As for my own experience, not to discredit all medical professionals, people tend to work better in response to their awareness of being observed. A second theme identified was they are in favor of FPDR to promote the right of the family of information. Nurse 4 was again classified under this theme because of the statement that the significant relative has the right to know what measures the clinical team would do during resuscitation. Another theme, to provide continuing link to support networks for the patient during CPR. So 3 of the 2 nurses and 1 doctor said that they are in favor of family presence during resuscitation because they think that it can provide support to the family, to the patient. Another theme, for the family and patient to never lose hope. Nurse 6 said that it is a form of emotional and spiritual support. What mattered most is they were there as a family hoping for something, maybe a miracle, may happen to their loved ones. If things get worse or even to the point of death, at least they have done something and they were able to show their love to the patient by their presence. And the last theme under in favor is to satisfy themselves that they did everything for the patient. One doctor said that to provide support to the patient and to see them for the last time, it is important that they know that they did everything for the patient. So the things identified under not in favor of family presence were the following. to provide medical information to the relative without the relative witnessing the CPR. Second, to avoid psychological trauma to the family. And third, to avoid conflicts among the healthcare team members. What is noticeable in the themes identified was to provide medical information to the relative because it is present in both the in favor and not in favor. The only difference is the respondents think that you can provide information to the family without the family witnessing the CPR. Although there were more not in favor responses, a lesser number of different keywords or themes were identified for the categorization of the comments. If it's a quantitative study, it's like there is little variation, or meaning the responses are almost the same. The majority of the nurses answered that doctors are the leader of the code and should make the decision about a family member being present during resuscitation. So, out of the doctors, out of the 8 nurses and 5 doctors, they all think, majority of them think, that the decision maker of having a family with the patient in the ICU is the doctor as the team leader of the code. So, Chapter 5 is discussions and ethical considerations. As I have said earlier, the objective of the study is to identify the factors in the practice and attitude of nurses and doctors on family presence in the ICU. These are the factors or challenges identified in the conduct of the study and more so in the implementation of the recommendations. The data collection was a little difficult. The healthcare team was reluctant to answer at first because they feel that their personal views would be contrary to their professional roles. But later on agreed due to the absence of a hospital policy. They think that they would not be litigated. While several nursing and medical organizations promote that 24-hour family visitation and family presence during resuscitation, almost all of the doctors and nurses disagree. This complements the culture of Filipino families of having close ties. Further, it matches with the result that most of the healthcare providers want to be present if their loved ones are being resuscitated. However, the result that most of the healthcare providers do not support long hours of visitation and FPDR seems contradictory. The participants seem to disagree as a professional, but agree as a family member. Thus, ethical dilemma makes the implementation of the program very difficult at first. With the culture of inferiority, of nurses to doctors was not evident in the result because most of the time, the nurses' views complement the doctors. Thus, empowerment of nurses in the decision-making is not a priority as of the moment. One important thing to note is the result where some of the nurses in the ICU are not ACLS certified. This can potentially become a problem in the resuscitation care delivery. However, in the case of staff working in a government hospital is that the administration does not only not support but also cannot afford training and continuing education. Why? Because only a few hospitals in the Philippines are provided a budget from the national level. In fact, the province of Pangasinan is lucky to have one. But the Pangasinan Provincial Hospital, which is the only tertiary hospital among the other 7 government hospitals which are subsidized by the provincial government, the Pangasinan Provincial Hospital do not cater pay patients. Meaning, all the patients hospitalized in the provincial hospital do not have out-of-pocket payments. Everything is free. Everything is subsidized by the provincial government and the National Health Insurance System or the PhilHealth. Therefore, potential additional expenditures in supporting family involvement, which include facilities and staff recruitment and training, are not possible because the budget provided is only for the hospital fees of the patient and for the salaries of the staff. Okay. The program is evidently not a priority by the provincial hospital. Even the basic requirements like the personal protective equipment for the family member to enter the unit is not provided. So since the patient in the provincial hospital do not have out-of-pocket payments or expenditures, only one gown is provided, and this will be used by all family members from admission to discharge. Can you imagine in other countries, one gown is provided every time a family member enters the unit. But in our case, in the Pangasinan Provincial Hospital, one gown is provided throughout the hospitalization of the patient. And this will be used by all members of the family. So, in conclusion, number one conclusion, while the doctors are all ACLS certified, some nurses are not, but they all participated in a code. Number two, both the doctors and nurses have greatly participated to codes, but with a lesser experience of having family members during a code. Further, they only have very few experiences of initiating family presence during resuscitation. Number three, the nurses think that the 5-hour visitation period is long and would want to decrease it. The local doctors prefer a no visitation hour rule, and the international ones think that visitation is also needed. Number four, the healthcare team prefer a no FPDR policy primarily to avoid delays in the delivery of care. And lastly, the healthcare team believe that doctors should make the decision of allowing a family member to be present during resuscitation. And 4 recommendations were made. Number 1, a memorandum of the standard operating procedure on FPDR from DOH. However, the specifics should be defined by the institutions. Number 2, follow-up research to consider including family members and patients as participants of the study. Also, a similar study conducted in all the other units of the hospital. Number 3, to provide support to the healthcare team by giving opportunities to continuing education. And lastly, explore whether the presence of a hospital policy allowing FPDR rather than merely actual FPDR to provide consistent practice in the entire hospital and to eliminate conflicts between doctors and nurses in such situations. The hospital policy must be specific and fit the needs of the patients, families, and the healthcare professionals. In the end, what we really aim is to provide patient and family-centered care and evidence-based practice. These are my references. Thank you. I'm ready for the comments and questions.
Thank you very much, Joella. Okay, we'll pass it to our examination team. Thank you. Rajesh.
Thank you for the presentation you gave. I have some basic questions to understand. Can you help me understand what is resuscitation? Right, and you have used some abbreviations, LVDR at the end, ACLS. So you can highlight that. Is there any kind of a cultural framework where in Philippines we say that nurses are considered inferior? Which should not be the case, because somewhere in the presentation you did mention that a very beautiful differentiation you brought between doctors and nurses as to amount of training what they get plus their regular education and the time they invest. So I believe their roles and responsibilities are different. So if this is a part of the education system in Philippines, so nurses are not inferior, but their jobs and responsibilities are different. That's how I look at it. You can highlight to me the objectives of research and also correlate these objectives with your findings at the end. Right?
Thank you, Rajesh.
Okay. The first question is the definition of resuscitation. So resuscitation is done when a patient or when somebody's heart stops beating. And of course, when the heart stops beating, breathing stops. So, in short, the patient is dead. So you revive the patient, you resuscitate the
So
patient.
you use a ventilator for that?
At first, you need CPR, cardiopulmonary resuscitation. Sorry. So CPR is you make the heart begin to beat again. Okay, it's like pumping the chest of a person to help the heart beat again. Okay, that is resuscitation. And when the heart starts beating, of course, it follows that the respiration or breathing begins also. After CPR, that is what you call life support or ventilator. After CPR and the patient is still not stable, but the heart is already beating, the breathing or the respiration is absent. That is when you need a ventilator or life support.
Sure.
Okay. So, about the acronyms, FPDR. FPDR is family presence during resuscitation. This acronym is accepted in the medical field. So, yeah, I know it will be new to you. Okay. And ACLS is Advanced Cardiac Life Support. ACLS includes the CPR or the reviving of a patient, resuscitation of the patient who died. Yeah, we call it died because the heart stops beating and breathing is absent. About the culture of inferiority, also in other countries, not only in the Philippines, nurses are seen only as helpers of doctors. Why? Because the doctors decide about the medical treatment of the patient, and the nurses somehow help in the implementation of the treatment. What people do not see is they have different responsibilities. Nurses also have independent roles. So one of the independent roles that I presented a while ago is a nurse being a patient's advocate. Okay, so it is important that nurses should be empowered also because nurses should be included in the decision making. Okay, we have a while ago the term shared decision making. Shared decision making is including all the members of the health team, not just the doctor, not just the family, not just the patient, including all members of the health team in decision making of the treatment of the patient. Okay. So the last question on the objectives. So
What are the objectives of the research first? Can I see that page?
Okay. The objective of the research is to identify the factors in the practice and attitude of doctors and nurses on family presence in the ICU. Okay. This is to recommend the establishment of a hospital policy. So the results, the factors in the practice and attitude. The conclusion. The factors identified are the experience, the certification, and on the attitude of the nurses on visitation hour, a number of visitation hour, and the presence during CPR. Okay. And what is the reason behind the perception is identified also. It is primarily to avoid delays in the delivery of care. And the last one, the decision making. Who have the right to make a decision if a family member should be present with the patient during CPR? Is it Is it the doctors, the family, the patient?
Wouldn't the criticality of the health of the patient decide that the family member should be visited, waiting outside?
That can be considered also, sir. However, my basis is that organizations, nursing and medical organizations, promote 24-hour visitation, presence during resuscitation, and special procedures based on researches that the family's presence provides a great factor in the patient's health outcome. So they promote 24-hour, no limitations.
So is there any hospital like that in Philippines which promotes this policy?
In my base hospital, sir, they promote 24-hour visitation. However, the problem is during CPR or during resuscitation, they do not want the family member to be present and leave the family member outside of the unit.
Yes, because it could be painful for them to see all
Yes, that was identified as one of the reasons of the healthcare members.
So, any cases we can cite, or are you aware of, that if the family members were present, then the patient's chances of revival was increased in a specific hospital? Any such study that has come up in this?
Yes, sir. So, this study, Hospital Policy on Family Presence During Resuscitation, it is a study an observational cohort study in the United States. This measures the outcome of the patient. So, the primary outcome, and a secondary outcome. So, the primary outcome is the resuscitation of the patient. So, if a family member is present, will it have a difference in the revival of the patient? And then the secondary outcome include the quality of the resuscitation, aggressiveness of the resuscitation, facility reported. So, primary outcome is on the outcome of the patient, in the resuscitation, and secondary outcome is on the process, which includes if everything was done, the aggressiveness of the personnel, that's it. And the result was, it was found out that FPDR was associated with more potential errors in vascular access and medications and delays in airway insertion and defibrillation caused by personal factors. So, yes, the result is somewhat negative. However, this is just one study. And organizations are still promoting family presence during resuscitation.
And one last thing, how do we define ethical practices in this? You use the word ethic, right? So what is ethical for this research?
Okay. What is ethical? Okay. I think the number one ethical issue identified is that as a family member, the medical personnel agree with the presence of a family during resuscitation. The dilemma is, why is that as a professional medical team, they disagree with the family presence during resuscitation? So the dilemma is, how would the policy be implemented when in the hospital, the healthcare team, which are primarily involved in the resuscitation, do not agree?
I have a question for you, Joella. Is that there? If I go to have a surgery and I'm having a heart surgery, do I, as a patient and as a family, do I prefer to have a very rude but excellent surgeon, or a very friendly old surgeon with shaky hands and not very good outcomes? Which do you prefer?
I think, sir, the first one. because the physiological aspect must be the primary priority, and the next ones are just the emotional part, psychological part. If the doctor is friendly, it's more on the psychological and emotional part, but the excellent doctor is on the physiological.
So if the outcomes from having a family present in the ICU is going to hinder because of the emotions of the family members and people getting upset or crying, with the potential outcomes as you cited the research, then although you personally have a preference to have a family member there, if the data shows that it's not so efficient, then as a medical professional, which do you think is better?
First of all, sir, that includes the cultural factor, because Filipino families have very close family ties, and every important situation in the life of a member of a family, they want all the family members to be present. So, as a medical professional, the question is, as a medical professional, based on my experiences, I wouldn't want no limitation family presence in the ICU. But however, I think we can negotiate on having the family in the ICU. For example, during the night time, when the nurses are not busy, when there is no special procedure, or when the climate is calm. But that is on the family presence. During the CPR, of course, the environment must be controlled. No time for mistakes, no time for delays. So as a medical professional, during resuscitation, I do not want any family member in the ICU.
Thank you. Are there any other questions from anybody? Angelica? Anybody else? Any other questions, anyone? Okay, Rowena first. Thank you.
Have you experienced cases of DNR in the practice of your profession? If ever there are, how did you handle it?
Okay, DNR or do not resuscitate requests only come from doctors and family members or patients. So why will it come from the doctor? Because the doctor know the condition of the patient. The condition of the patient in cases like they know that the patient will not, for example, if the patient is in coma, will not wake up, or if the condition is very critical and there is little chance of recovery. Okay. So in some cases, like a family member requests for a DNR, ethical issues again arises because the family member sometimes we see the family member as they cannot afford anymore seeing the suffering of the patient, because money is not an issue in our hospital, everything is free. So the reasons are always the patient is suffering long enough, he needs to rest, and he's already satisfied with his life. So that in that cases, in the book it should be discussed in an ethical committee of a hospital. However, the problem is our hospital does not have an ethical committee. We are still looking for establishing an ethical committee. So in our hospital, the cases are if the family member requests for a DNR, we have discussions. We have short discussions, but then if the family still insists, even though we think that the patient can still survive, we follow the request of the family.
Okay, thank you. Angelica, please.
Joella, Estrada. Well, most of my questions were already asked by Dr. Aurora, but in a nutshell, I'm interested to know the impact of your research. So what do you think is the impact of your research to the community and the impact of your research to legislation and policy enactment?
I will answer first in legislation and policy enactment. So, it has been shown in the study that most of the nursing and medical organizations promote family presence. However, the result of the study says otherwise. So I think more studies need to be conducted. Why? Because there is contradiction. So, if a healthcare professional will do something, does something that is not complementary with what his or her beliefs or opinions, that would be difficult. Difficult for the health team member and for the patient also, because he won't function properly. Okay, so in the community, the result of the study actually favors the community or the family. If a family or the result that the healthcare team members disagree means that there is a problem in the hospital. There is a problem in the hospital. Therefore, a policy must be established for the family, for the option or for the what do you call this? For the decision of the family to be considered also in the hospital, because in the hospital it's always the doctors who are found and not the family.
And this is a good study. Now, the result of your study, were you led to submit it, so that there will be a follow-through or somebody or whatever agency, were you led to submit it?
First of all, ma'am, in our hospital, I think the result of the study can lead to establishment of an ethical committee. First of all, an ethical committee, an institutionalized policy, and after it has been settled in the institution, it can be submitted to the provincial hospital, because the provincial government, because the provincial government is also involved, because our budget in the provincial hospital comes from the provincial government. After the provincial government, of course, to the national level, the DOH, for the DOH to provide a standard operating procedure, a memorandum on standard operating procedure. So are there any more questions? I know this topic is new to you because most of you are not in the medical field.
Okay, maybe go back to the front. Yeah, thank you. Any other questions or comments?
So you've made a few notes, quite a few notes. So one of the revisions that would be interesting to develop is the implementations of the model, and maybe some in-depth discussions with some of the practitioners. They gave us some reply. And we've also discussed the difficulty it is to follow up ethically with family members and people who lost their family members. And it's against the hospital policy. That it actually would be very interesting to have their perspective. You referred to the cultural aspects of the whole of life and the importance of family members around when you're dying, which could be more explored in the thesis with a bit more literature on the culture, I think, in that. So in the revision, to add that aspect as well would be good. And to clarify the data on the outcomes. What are the statistical outcomes? And I think we can say congratulations to Joella. Good job. Revisions to do as well. Okay, thank you very much. Okay, good.